And email and website. I'm a physical therapist in private practice, and I belong to all these groups. And I'm basically a practitioner using fascia manipulation. I have been a clinician for 40 years. I have migrated to this technique because I see how much good it does. And today I want to share with you more on all that it can do for foot problems. So there's a lot of information in the literature on all different kinds of foot problems. It's a lot to wade through, but I think one of the best books I've ever seen was written by this doctor, famous doctor, and it's Dr. Seuss. My husband actually used to carry this in when he was seeing a foot patient, but he writes about up feet, down feet, clown feet. So anyway, I needed a laugh at this moment. So there are a ton of diagnoses that deal with foot problems, and I tried to list as many as I could on here. I couldn't even fit everything. So if you don't see yours on here, it's probably just because it couldn't fit. But what a lot of these coexist, so people harbor more than one. And what a lot of people don't consider is that many of them can possibly stem from a similar source, which is the fascia, which is what I'm going to be talking about. There's lots of tests for the feet. And as with most diagnoses in healthcare, the ones that I think we deal with the most are in red here. And so these are the ones I'm going to try to cover today. I lost a little bit of time here, and I really want to be a respecter of people's time. But the ones in red are the ones I'm going to say more about. And a lot of them overlap as well. So let's start with just taking a look at bunions, because bunions are so common. So the most common type is called a hallux valgus, and there's an X-ray image of, it's not that same person's foot, in case you can't tell. But what we also see in the X-ray image is there's two kinds of bunions. There's the hallux valgus, which is the big toe, and then there's the talar bunion, which is the little toe. And both of them, they kind of drift toward each other. And they can be symptom-free. They aren't necessarily painful. A lot of times it just causes more cosmetic distress, but they can become red, swollen, and painful. Footwear is a challenge, trying to get shoes that fit, especially if the bunions are really advanced. You can see the prevalence here. The etiology, it's mentioned a lot about a genetic predisposition, but there's other things as well, including the fact that women have more bunions than men, might be due to the shoe wear that women choose. So I want to say just another word about genetics. As I went through the literature, I can find a lot of articles about bunions, but the genetic component is a source of debate. And no one's done a thorough study that proves it's genetic. We think maybe just more the predisposition or other characteristics of the body would predispose somebody to having bunions. But you don't inherit your grandmother's bunion, even though I hear that said a lot. I think one characteristic that truly is genetic is hypermobility, which is just excessive mobility at all parts of the body due to a lack of collagen in the connective tissue. But nonetheless, the AI overview says that the genetic predisposition is a major factor. So I think it's an element, but it's really not the whole story. Weight is also often blamed as another predisposition, and it seems intuitive that weight would load the feet more. It does. But in my years of practice, I've never seen that heavier people have bunions more often than thin people. It doesn't seem to correlate that way. I think there is universal consensus that footwear does matter, but what constitutes good or bad footwear is kind of subject to debate. So I think we can look at these pictures of the female shoes in the top corner and the whole along the row here. Intuitively, they're not ideal. And when I went back, and some of these are my shoes, actually, I took pictures of, but the ones I put in frames are the ones that I think are good examples of what I would consider better footwear. The yellow shoe down here is probably not very supportive at all, and neither is this black tennis shoe. This one, you can look at it and tell it's got more support. This is a good sandal if you're going to wear a sandal. These are supportive looking boots. I'm not a big fan of the minimalist shoe wear, especially for running, because it's such high impact. Some people love it. So whatever works, but I'm just sharing my perspective on it. So on my website, I have a whole blog post that has a video in it on how you can pick up a shoe and judge whether or not it's good, supportive, and ideal for you. I made this slide because these are some of the ones that I have, and I have found them to be really, they work well for me. I like the brand and they tend to be pretty supportive. The ones that are down here in the corner in the square, they I hear a lot of people say that they like them and that they're good, but I just don't personally own them. I do believe footwear is the most important piece of clothing on your body, but you don't have to pay a fortune to get a good shoe or a good footwear item. And just because you pay a lot doesn't mean that you got a good shoe. You can pay a lot and get a bad shoe. Another point I'll make is that a lot of people, when they get home, they sort of slack off and they want to chill out and ditch the shoes or wear something like flip-flops. I'll say this, your feet don't care where you are. They care more about what you're doing. And when I'm at home and I'm on my feet, I like to give them support. If I'm going to be on the couch, I don't care. It doesn't matter. But in weight bearing, I believe they do better for you and they'll treat you better with support. So, in terms of bunions or hallux valgus, in the realm of treatment, there's several options. Like you can do nothing, you can use ice, orthotics, shoe inserts, toe spacers. There's all kinds of products on the market. Ultimately, surgery. Um, so basically, what's the outcome of these? Well, if you go in the literature, there claims to be an 85 to 95% success rate for bunion surgery. But I think it's good to ask the question, well, how are you measuring success? What is the surgery and recovery like? How long does it last? Like when they're getting that 85 to 90% success rate, are they looking at people? How are they 5 years down the road or 10 years? Often people have to have a repeat surgery done. And I think it's because the actual source of force that's causing the bunion isn't taken away with the surgery. It just takes away the symptom, which is the bunion itself. So ultimately, the outcomes are rather disappointing for people. And I would suggest that maybe it's because we're missing something. And we'll come back to that thought some more. So talking now, another foot diagnosis, plantar fasciitis. This is a pretty common one. It has different names, fasciitis, fasciosis, fasciopathy. They're all talking about the same thing. People renamed it over the years because it doesn't seem to respond to being treated as an inflammatory problem. So there's a fair amount in the literature on plantar fasciitis. Most of it says pretty much the same thing. This is an article from the American Family Physician. So your physician might read this, and then this would be the guidelines that the physician might follow if they'd have you in front of them or someone else for plantar fasciitis. But basically, symptoms on the bottom of the foot, worse first thing in the morning, worse with standing up after periods of sitting. 1 in 10 people, I would have thought it would be higher than that. So the etiology, meaning, what is it? What causes it? It's common in runners, but it can also affect sedentary people. So since we're at both ends of the spectrum there, obviously we don't really know what causes it. So the etiology is unknown. Treatments are typically, like you see listed here, stretching the calf and the plantar fascia, like you see in the picture, ice, golf ball or lacrosse ball, tissue work on the bottom of the foot, physical therapy, NSAIDs, injections. Orthotics and night splints haven't been shown to really be helpful. So what's interesting to note is that 80% of most people improve within 12 months, and some of them with doing absolutely nothing. So it really makes you wonder, are these interventions actually working? And I will say too, improve doesn't mean resolve. It just means something's not as bad as it used to be. Again, I would suggest that maybe we're missing something. And by the way, this is one of the few diagnoses that even acknowledges the existence of fascia. Diagnoses, not just for the feet, but anywhere in the body. There really isn't another diagnosis that has the word fascia in it. So kind of interesting on that level. Over the years, I have noticed that many of the patients I see for problems anywhere in their body, they often have a history of issues that's positive for the calf or the foot. It may have been a long time ago and it may be completely symptom-free, but I would suggest it's still exerting an impact. So I always specifically ask people about a history of problems in their feet and their calves because they have a tendency to forget. When the symptoms are gone, they forget that the problem was ever there. But the problem, the old problem, may still be exerting a new impact somewhere else in the body. So let's take a look at a heel spur, which sometimes goes along with plantar fasciitis, but not always. You can have one and not have the other. Heel spurs can happen anywhere, especially near a joint, and they're the result of abnormal tissue pulling. And you can see examples all over the body here in the neck, in the back, the knee. There's one on the top of the foot that's called the dorsal bunion. I'd never heard of that till I got this stuff ready. But it's basically a manifestation of an abnormal force being exerted that's impacting a bone. And here's another example. This is called the Haglund's deformity. So this is the calcaneus or the heel, and this is the deformity, and it's happening. It's also called a pump bump, by the way. Not really sure why, but it comes from, this is where the Achilles tendon is going to insert onto the calcaneus. And because if the Achilles tendon is pulling abnormally and the fascia and the muscle are dysfunctional, then they're going to exert an abnormal force. The bone lays down more periosteum. It's just trying to fortify itself against that pull, and so the bone gets bigger right there. It's kind of like, I think of it like a connective tissue tug of war, where it's just the pulling and the force, and it's the way the body fortifies itself. We tend to focus on the spur as the primary problem, but it's really not. It's just the symptom resulting from tension somewhere else. So cutting the spur is not necessarily going to help because your body's going to just start over fortifying itself. So the treatment for heel spurs is often the same regimen as for the plantar fasciitis, and it's very similar. So how is all this working? Not very well. The literature shows a lot of unhappy people with poor outcomes. And again, I'll say maybe it's because we're missing something. So I want to look at peripheral neuropathy here. This is one I hear people mention a lot, and I hear a lot of people suffering with it. So the symptoms can be like numbness, tingling, hypersensitivity, often on the bottom of the feet, but not always. It doesn't have to be. Prevalence is like 7 to roughly 10%, which is a lot of people. So if I go to AI and I look up how does AI define peripheral neuropathy? It has this word damage in it. And I would argue against the use of the word damage because peripheral neuropathy is often diagnosed based on what somebody's symptom report is. You can't know for sure that there's nerve damage unless you do some testing of the nerve, but it's often diagnosed without testing. And for that reason, I don't think we can't say with certainty that there is damage. And yet, damage is a recurrent theme over and over. When you look at what AI says about these are the 3 types of nerves, sensory, motor, and autonomic, that can be involved in peripheral neuropathy. But again, they're using this word damage. I think the word irritation is a better word. And so if you think about it, irritation of a sensory nerve could involve the temperature component. That could be where cold feet come into play. Irritation of an autonomic nerve could impact abnormal sweating, and that could be a factor for people who have excessive sweating in the hands or the feet. It's called hyperhidrosis. So there are lots of proposed causes for peripheral neuropathy, as you can see here. And diabetes, vitamin deficiencies, alcohol, medical treatments like chemo, trauma and compression are the most common issues causing peripheral neuropathy. And many people have trauma or compression on top of diabetes or on top of chemotherapy. So that only worsens the symptoms then. So entrapment neuropathies, I've got them listed here. Things like sciatica, compartment syndrome, Morton's neuroma, carpal tunnel, thoracic outlet, all of those are examples of trauma or compression type symptoms that can cause peripheral neuropathy. So here are some common treatment strategies and suggestions. So first, of course, if your diabetes is a factor, you want to manage blood sugar levels. You can try medications, but I'll have a little more on that in a bit. And lifestyle adjustments, including physical therapy to help prevent falls. So this article took a look at some of the interventions for peripheral neuropathy, including physical therapy. And this is what that they had to say. Many of the meds used are not very effective and unfortunately have very strong side effects. Alternative approaches like physical therapy get attention because people are looking for help. Now, what does that look like? Well, Physical therapy for peripheral neuropathy focuses on improving balance, reducing pain, and maintaining mobility through exercises. And here's just a deeper dive into it. And all these things are good. These are all positive interventions. But bottom line is, how well is it working for people? Well, it might be good. At least what they say in that end here is that adverse events seemed rare. So that's good. We know all of these interventions with physical therapy aren't hurting anyone, but ultimately they're not helping enough to where the recommendation is that physical therapy should be used in the management of peripheral neuropathy. So that's kind of disappointing. But again, maybe it's because we're missing something. And what I want to do now is take a look at this research that looked at Morton's neuroma. And here's what they use. They call it instead Morton's syndrome because it's not a true neuroma. There is no tumor. There is no neoplastic tissue surrounding a nerve. So they prefer Morton's syndrome. Sorry. And there's no agreement on a gold standard for treatment. And typically, the classic treatment is cutting out the nerve or else like cauterizing the nerve using heat, using cold, and temporarily disabling the nerve to stop the pain. But they're saying in this paper it's an entrapment syndrome, although we don't know what's entrapping it. The cause of compression isn't clear. So in this same study, they dissected 11 feet of male and female, and they also examined the feet of live subjects. And some of them had Morton's syndrome and others didn't have any symptoms at all. And they looked at it through MRI and ultrasound. And this CDPN here, what they're showing is these are the bones of the foot. I had a cadaver picture, but I took it out. I figured at lunchtime that's not a good idea. So these are the bones looking like this at the foot. And they're talking about the common digital plantar nerve. And so this is what they concluded. Alterations in foot support and biomechanics act on the muscles, increase the stiffness of the fascia where these muscles are inserted, and the rigidity of this fascia increases the stiffness of the spaces that entrap the nerve in between, the common digital plantar nerve. So this article further supported the construct that the fascia was an important element in nerve entrapment and neuropathy. And they just stress the importance of fascia in a lot of these symptoms, and people are overlooking it. So Dr. Carla Stecco is a world-renowned anatomist and researcher. She wrote this paper talking about how fascia is often completely overlooked in research, in anatomy, and in medical practice. And she said this in her book, just as descriptive anatomists have omitted important fascial structures in their research, so has medical treatment when it focuses only on muscles, joints, bones, organs, tendons, and ligaments. It's a big oversight, and I would agree with her on that. So in this paper from the Italian research team at the University of Padua, they showed these images of subjects with plantar fasciitis. So the stars are where there is increased thickness in the plantar fascia. And the top image is an ultrasound, and it's showing the thickness here because the sound waves can't pass through it there. So it comes out as a different color than the other tissues. The B, this one down here, here's those stars, and it's showing focal thickening right around the attachment of the plantar fascia on the heel. And then this is another type of MRI showing edema and evidence of inflammation in the very same place. So pretty cool imaging where we can actually see some of the problems. This paper they did shows that they're saying there's a strong relationship between the plantar fascia and the Achilles tendon. The plantar fascia is not a lone ranger in there. It functions very closely with what's going on at the Achilles tendon. And this paper, they showed that when you moved the Achilles tendon and the calf muscles, you also even had movement at the pelvis. So we're starting to get this idea that there's a relationship all over the body between what happens down at the foot and at the Achilles tendon and the calf, even all the way up into the pelvis. And I find this in practice. This article showed moving the neck, you could get a change in cervical mobility, your neck mobility, by just applying some lower limb stretching. So really supporting these constructs of continuity all over. So this article looked at the long-term effects of ankle sprain, and I totally agree with this, that there are effects on postural control, sensitivity of the fascia in the calf and the foot. I've often said that an ankle sprain is the most underrated injury to the human body. It heals up, but what doesn't get restored is the slide in the tissue layers. This study looked at using fascia manipulation in managing chronic ankle instability, and they concluded that it was very helpful and it should be included in ankle regimens. So here's an article talking about Morton syndrome and how they used fascia manipulation. I'm going to move a little faster through these because I'm really trying to catch us up for time here. But back to, they don't really know why it happens, but it's compression on the common digital plantar nerve. No consensus on what's the gold standard of treatment. And usually people go to surgery when conservative care fails. So what I pulled in here was an article showing what's the long-term results of neurectomy in the management of Morton's neuroma. Not a good outcome. So a lot of these people ended up worse after a 10-year follow-up. So not a nice option. So back to what they were doing with this article on for fascia manipulation for Morton syndrome. They had 9 patients. They had Morton syndrome for at least 4 months, and they went through 3 sessions of fascia manipulation. The pictures show the foot, but what I wanted to do was put this in so you could see they didn't just work in the foot, and they actually didn't even go to the foot for most of the patients. Even on the first visit, they treated all over the body, but they went up as high as the lower back. And they got a very nice outcome with 3 visits and a 3-month follow-up. They were still continuing to improve. So their take on it was that you get micro trauma alteration in foot biomechanics. It makes the fascia rigid. It compresses the digital nerve, and you get pain. And that's the pattern and the model that they based it on. And this is the first time I've been able to put a smiley face on any kind of intervention. So that was using the FM for the foot. So this is not just confined to the foot, but this is a literature over a 10-year span talking about fascia manipulation being used all over the body for all different conditions, musculoskeletal and internal organ. And they give it a very nice review that basically it appears to be a potentially effective strategy. So I want to tell you a little bit about what fascia manipulation is like. It's a system that respects the continuity of the connective tissues and the relationship from the head to the toe, right to left, and front to the back of the body. And it began in the 70s with Luigi Stecco. I am pictured with him in Italy there. He just wanted to bring different constructs of our understanding of anatomy as well as how we treat people and see if we could do better. And so he's been writing since the 1970s, and I became certified over there, and then I went on to become an instructor. FM is taught all over the world. The US has been slower to catch on, but we're trying to catch up with that. So it begins with getting a history all over the body, including past problems and things that appeared to heal. And I'm really interested in old problems, like if there's an ankle sprain, but I want to know about everything else that's going on. We look for clues. How's the body being pulled? Like, do I see hammer toes? Do I see bunion deformity? Do I see a high arch, pronated feet? And here's an example of that Haglund's deformity, that pump up. So the next thing we'll do in fascia manipulation is we'll do movement testing. And maybe you can see here, this hip is not going down as far as this hip. And that may very well have an impact on the foot, certainly could have an impact on the hip. There's lots of ways to test movement. There's no one formula, but it's nice to get some movement testing in. Then the next thing we do in fascia manipulation is palpation. And I use my fingers, I use my knuckles, I use my elbow a lot. And what I'm feeling for is I'm feeling down to this deep fascial layer in here. It looks like it's one thick layer, but it's really not. It's 3 layers of tissue, collagen and elastic, and they have lubrication in between them so that they are able to be spaced apart and they slide on each other. And that comes from the mechanism of hyaluronin or hyaluronic acid, which is getting very much attention now for beauty and skincare. So A depicts normal, where we have space and we have mobility between the layers. B represents where there's been overload to the tissue and it becomes compressed and it sticks together. It's called a densification. And how does that happen? It happens from the tissue being overloaded. And overload can stem from the hyaluronan becoming, it almost changes character completely. And instead of being a space creating lubricant, it becomes a space occupying adherent. And it can happen from an injury, like an ankle sprain. It can happen from repetitive movements, like running, or it can happen from immobilization, like too much sitting or being in a cast or a splint. But the good news is this process is reversible. And this is what we're trying to do with our techniques in treatment. We're trying to take it from stuck together and densified to restoring space and slide. So in treatment, my go-to is fascia manipulation, but I also use percussion devices. I use cupping. I use dry needling some, not as much as I used to because I just migrate more toward the fascia manipulation method. And I teach patients how to work on themselves. I also use these percussion devices in the clinic, and I teach people how to use them on themselves at home if they will get one. I hope I'm not going too awful fast. I'm at the point where I want to share some suggestions for how you can think about taking care of yourself and your feet, your calves. I hope you can see that's a big part of it. So my first suggestion is consider movement as being one thing to pay some attention to. And you check out your mobility. A foot and an ankle problem can restrict a hip, and a hip can also mess up a foot. And you can see the difference here with this subject, how this leg's going down pretty normally. This one is way up by comparison. Something is restricting that hip from moving. And very often I find these restrictions are down in the calf and the foot or into the heel itself. So I have on my website under the resources tab, I have a movement assessment video, and I would encourage you to consider taking a look at it. I walk you through what's normal. How can you check yourself out head to toe, check yourself out and just do a general screening for are you missing anything anywhere? And it's worthy of attention because if you don't use it, you lose it. And over time, we have a tendency to slowly accept that as we age, we're going to get less and less mobile and flexible. And I really think we have more to do with how that looks over time if we would just pay attention to it and not get so far behind with it. This is one of my favorite stretches I use a lot, a doorway lunge. And it's nice to counteract the effects of sitting because it's going to open up the front of the hip. It's going to stretch out the calf as well. I really suggest you keep your foot straight and your heel on the ground. And then if you can do it in a doorway or at a wall, you can also get a stretch of opening up the upper body. So it really hits several areas of the body that we have a tendency to just gradually get shortened and restricted in. Another form of movement that I like is using ball exercises. Balls are all different sizes, but you want one where you're going to basically be at about 90 degrees of hip flexion and knee flexion. So the taller you are, the bigger your ball would need to be. I have people move in the frontal plane, which is like, front to back like that. I'm sorry, sagittal plane is front to back. And then the frontal plane is like a windshield washer or wiper. So you're moving side to side, and then the horizontal plane. And that kind of covers everything that the three planes of movement that your pelvis would need to be coordinating. It's fairly easy, but if some people need to hold on for balance. Personally, I like hula hoops, but that's a higher level of exercise. But it really is a nice tool for working on trunk mobility and stability. And then whatever your exercise love is, whether you like Zumba, Pilates, I like biking. So I like to get out on my bike when I can, walking, whatever. But movement is key to life. Okay, my second suggestion that you consider for helping your feet is your footwear. And I've already touched on that. So you've already seen what I consider to be a better shoe. This shoe to me is more likely to be supportive than this one. So I have on my website again, I have a blog for everything practically. And this one was on supportive footwear. I have a video in there showing how you can pick up a shoe. So have a look at that and it'll teach you how to be your own critic of what you have or what you're considering buying. instead of having to count on somebody a salesperson in a store who wants to sell you something that's maybe not exactly what you need. So my third suggestion for you to consider is getting a percussion device. And these have really grown tremendously in terms of popularity. When I first started using them, there was only one on the market, one or two, and now there's so much more out there. But what we're doing with a percussion device, I apply it to the points where the fascia is densified in a model that correlates with, what am I working on in maybe in the hip, and what am I working on down in the foot? They may be the same point, just in different segments. But it's an easy to use tool. Most people love it. And then when it comes into the household, everybody wants to use it. So they're really neat tools. I have some suggestions on them. But what we're doing with it is we're helping to promote that reversal of from being densified and stuck to promoting that space and that slide. Percussion is a vertical force, and that's not as powerful as what we can do manually with a horizontal force, but it still helps. And it's very usable for people at home. It's hard to work on yourself and get the manual effect of the shear force. So this is the device I use. I have the Hypervolt. It's made by Hyperice. It's an awesome, awesome tool. I thought I didn't have this one circled, but a lot of the devices out there, they leave out this accordion head, which I have right here. And it's nice, like, especially if you're going to do a bony spot like over ribs or the top of your foot. This lets you just cushion it a little bit more so you're not beating up the bone. You can bruise your bone, and there's no value in that. So, but check out, I mean, there's plenty of other devices out there, but I really suggest you make sure it has this kind of a head on it. I also, guess what? I have a blog post on percussion devices on my site. It's under resources. That's where all my blog posts are. And I give some suggestions in that post of another kind that is a little bit less expensive than, this is the one that I use here. It's pretty heavy, and it's sturdy. I've had this thing for probably 6 or 7 years, and they are still running, but they're a little more expensive, and I don't think people need to pay as much as I paid for this. So I have some good suggestions on my site. Now, the big question everybody always asks is, where should I work? What should I do on myself? What's the best place to go? I'm giving you these two charts. I think they were attached in your last email that went out so that you can download them. We're not trying to keep secrets or anything, but I don't know how to tell you. There's no way I can tell you without palpating which are the points that you need to work on, because it's different for everybody. It doesn't matter if you have plantar fasciitis or Morton's syndrome or heel spur. It could still be different for two people. Two people have heel spurs, but one's got problems in one point, and somebody with a heel spur has a different point that's a problem. It depends on palpation, but just keep in mind that where it hurts isn't always where the problem is. And I put this one in too. This is talus, is Latin for ankle. So often the problem in the foot is really stemming from dysfunction in the calf. The calves are a hotbed. I work on so many calves on people. So just have a look at some of these points on yourself. You are not going to hurt yourself if you're percussing on something and it's not the best point for you. But try to see if you can find, using these guidelines, just where these points are. It's the best I can do in this kind of format to just give you a little bit of direction. So manual techniques I do on other people. I work on myself all the time. And what you see me using here is what's called a 3 tool. And I have a slide coming up on it. But what I'm doing here is I press down and then I slide. So I'm applying pressure to get to the deep fascia. And then I'm working manually to break up where that fascia is stuck together and take it back to its spaced and slide construct. So this is the 3 tool. And I really like it. I have several of them. I have it at home, and what it lets me do is on myself, I can reach places and treat myself a little better than if I don't have that tool. I also like it for some places in the foot. A couple different points on the charts that I gave you. This thing helps nicely. You can get it on Amazon. I don't sell anything, but it's on Amazon. It's like $36, but nice little tool, very durable. So one last suggestion I'll mention is cupping. I will say I don't do a ton of cupping on feet. It just doesn't seem to be as much the right thing to do. When it is the right thing, it can be very helpful, but it's just not as often the right thing. You see these cups here. I don't do that very often, but this person wanted to try it. And so there's no harm in it. And so I took a picture of it. But cupping, I teach people how to cup on themselves, but it's not just, well, let's try cupping and see if it'll help your problem. There are very specific ways to know whether or not cupping the hypodermis is or isn't going to be helpful. Um, I have both of these kits. They're relatively cheap. They're like $35. The difference between the two of them is this one has some curved cups in it that let you get around joints a little easier. But I have it coming up here. I have a blog post on cupping. So if you're interested in exploring more, you can check that out and see what I have to say there. So, lastly, my last suggestion is just get help when needed. And if you're stuck in a rut and you don't know what to do, reach out to me. Okay. I'm happy to try to help you any way I can. I offer free sessions, not for treatment, but just a chat kind of beyond what we're doing here. And if that appeals to you and you want a little bit more guidance, I'm happy to just reach out to me or go schedule a time on my site. All right. So thanks for putting up with me earlier. I'll have to talk with my friend Whitney some more about doing a screen share on a Zoom platform. But anyway, I appreciate you all being here. And here is my contact info once again. And my plan is this is recording. And so my plan is to tidy it up a little bit and then share it with you guys or share the link with you and put it on YouTube. So I'll let you know when I get that. So I'm going to stop my screen share so I can go to the chat and see. So let's see. What are the best ways to treat plantar fasciitis? All right, that was from Jim. The best ways, it's most often the calf. The calf harbors, I find, more dysfunction than the foot itself. But if that calf is pulling for a long time, it can start to make those changes, those bony changes in the foot. But people stretch the calf and they do all this icing and stretching and heating and all kinds of stuff like that. But it's that's not going to break up whatever may be stuck together in the fascial layers. And that's the key thing that a lot of people miss. You need to get something to break up what is stuck together. The percussion it's good, it's helpful, and it would feel you'd probably be surprised putting it on the calf how lit up the calf of a plantar fasciitis foot is. Calves are they work so hard for us, whether we're in sports or our daily lives, our work day. We just, the calf is like our mule. We just work it to death. And they get loaded over time with fascial densifications. I'll tell you, the one that's in the dead center of the calf, I treat that a lot on people. Dead center between the two heads of the gastroc, right in the middle of the calf. But that doesn't mean that's what's driving everybody's plantar fasciitis. But that is one I do on a lot of people. But then stretching is good after you work on it, but it needs to be worked on. And it's possible. I mean, I treat the back of my calf with this little guy. It's not as ideal as somebody else doing it on me, but I do the best I can with it because I can't always get somebody to help me with it. So you could try that and see if that's helpful for you. Okay, best footwear to buy. All right. Well, Cheryl, I hope I touched on that. I feel like unmuting you guys, so let me try that. I don't know if I'm trying to figure out how to unmute you all as a group, but I don't know that I can. Anyway, sorry, I'm running over here. So best footwear, I hope I covered it. Love the footwear guidance video. Oh, good. Thanks. Thanks, Cheryl. Thanks, Cindy. Yes, you did. Okay. I don't know I don't see the button to unmute everybody. So if somebody has something else, please just type it in the chat real quick. Or I really keep telling it to Oh, you can unmute yourself. I just gave you power. So if you want to unmute yourself and ask, go ahead, feel free. If there's something else I didn't touch on, and I'll stay on for another minute, but um, is there anything else? No? Really? Yeah.
One question. Am I unmuted? Okay.
Yeah.
So thank you. That was fantastic. So much info. So I am showing up because I see a lot of clinical issues in my practice, and I was looking for learning more about what you do for like referrals. And I know you work with one of my clients and took really good care of her. So one client that I've been working with for a long time has rheumatoid arthritis and has been dealing with hammer toes. And I'm personally, knock on wood, my feet are fantastic now, but I've had a lot of trauma and body work and acupressure and everything. And so I'm in a really good place, but I see that a lot. And also peripheral neuropathy, I feel like I have some ideas from the presentation. So you gave me some good points there. But I'm curious, what might be some of your suggestions for hammer toe? I'm assuming fascial work, but anything else?
Well, hammer toes are unique in that it's almost pulling, it's like taking the foot, and like I think about it like a marionette, where there's like this force, the strings are being pulled,
Mm.
and they're pulling the toes, as opposed to a different force for the bunion, whether we're talking the hallux valgus or the bunionette, just totally different forces. Hammer toes are going to come usually from, I can't go back to my picture, so I'll try to just show you guys. But on my calf, on the front. So it's like this force right over here. You have on your pictures, okay? You have 2 points here, and one of them's called anti and one's called latero. And there also happens to be some very important neurovascular structures in between there that can get pinched and compromised and give us spider veins and varicose veins. But these two being densified will pull on the second one, the extensor digitorum longus, is that it's what goes to all the toes. So it's abnormally facilitated, and it's extending or pulling the toes up like that. Now, it doesn't mean that's the only problem, but when I see that kind of foot in front of me, I'm thinking I'm going to be I'm going to be in that corridor, or I'm at least going to look at it. But it's so often very positive in that place there. And that's why that foot looks so different than, and it usually is also a real high arch foot, because that's the direction of the pull that it's coming from. Um, I see it. I mean, I see people with rheumatoid arthritis who don't have hammer toes, and people who have hammer toes who don't have rheumatoid arthritis. So I don't think they are necessarily, always whatever you would call that, together, married. But yeah, the feet, I mean, even if there truly is a rheumatic or an inflammatory systemic, autoimmune disease going on, I think you can still, if you can change what you can change in the fascia, then maybe what you can't change with some of these other problems, it's not going to be as impactful. You can lessen the impact of the autoimmune disease. You can lessen the impact of the effects of the chemo or the diabetes if you just take care of the problems in the fascia that will respond. Because these people have the same fascia that we do and the same problems, but then there's other things on top of it. And that's where I think we can do so much to help even in these awful diseases. So that's a good question, Whitney. Thank you. Did
Yeah,
I?
that's insight. And my suspicion was it could be separate issues. That was coming from a rheumatologist that she needed to get out of that care was really bad, but it was kind of like pushing her to do things because it was the RA. And I was like, I'm not sure it's that at all because she's been doing so much better, like got her energy levels up, nutrition. She doesn't have any other symptoms, and she hasn't done body work though. I've been honored to do that, and I think she's ready now. I think that would really help her
Yeah.
out.
Yeah. Well, and the drugs that rheumatologists prescribe, they are wicked. They are very powerful. And I feel like if we could just get them more mobile and less painful, doing something like you say, body work, which, is what I'm doing. I just think it deserves consideration for people anyway. So yeah, good points. All right, you guys, I'm good. I need to go. But is there anything else anybody want to throw out there? Good. Well, thanks again for coming. Sorry about the faux pas. Yeah, Whitney, I'll be talking to you about what in the world I need a, that's always my worst fear. I love presenting. I don't get stressed about presenting. It's the tech stuff that just yeah, it makes my blood pressure go up. But anyway, all right, you guys, I'm going to end the meeting. So I will get this out to you. And thanks again for joining. I appreciate the help, Rini and Whitney. Thank you. See you guys.